Welcome to my presentation on the maternal health of urban southeastern black women in the United States. My name is A.Stewart, and today I will explore how structural racism, policy environments, and social determinants of health influence maternal outcomes for black women living in the urban areas of southeastern United States. This population faces disproportionately high rates of maternal mortality and morbidity, not because of biology, but because of systemic inequities within healthcare systems, economic structures, and community environments. In this presentation, I will highlight data, explain underlying factors, and offer potential strategies to improve outcomes and move towards equity in maternal health. This presentation focuses on black women living in urban areas of the southeastern United States, particularly in states like Georgia, Alabama, and Louisiana. These regions are marked by high levels of poverty, limited access to comprehensive reproductive health care, and systemic racial inequities that persist across generations. According to McDormand et al., black women in the United States are over 3 times more likely to die from pregnancy related causes than white women, and this gap is even more pronounced in urban southeastern areas. These communities often face shortages in maternal care providers, fragmented postpartum support, and reduced hospital quality, especially in areas that serve a high proportion of Medicaid patients. In many of these cities, restrictive abortion laws, reduced Medicaid expansion, and underfunded health departments create additional barriers to timely, high quality care. This impact is not just medical, but social and structural. These conditions make the southeastern urban black population one of the most vulnerable maternal health groups in the country. The social determinants of health impacting this population include income, education, access to care, housing stability, and experience with racism both inside and outside the healthcare system. For black women in the urban southeast, these determinants often intersect and compound. Many studies, including Bison et al. 2022 and Joku et al. 2023, show that racism is not just a background factor, but a direct influence on maternal health. Structural racism contributes to neighborhoods' disinvestment, unequal educational opportunities, and limited access to quality provider. Ross et al. Found that socioeconomic status offers less protection for black women than for white women when it comes to conditions like preeclampsia. Higher income or private insurance did not reduce risks in the same way, suggesting that the stress and discrimination experienced by black women override traditional protective factors. Other determinants include the quality of provider interactions, the availability of culturally competent care, implicit bias in medical decision making, often delays diagnosis, underestimation of symptoms, inadequate postpartum follow up. Together, these factors explain why this community continues to experience elevated maternal health risks regardless of individual behavior or effort. The epidemiological data surrounding maternal health in this community are striking. According to McDonald et al., the maternal mortality rate for black women is over 3 times higher than that for white women, and the leading cause of death include eclampsia, postpartum cardiomyopathy, embolism, and hemorrhage. These conditions are largely preventable with timely, high quality care. In southeastern states with restricted health policies such as Georgia and Mississippi, the numbers were even worse. Vita et al. Found that each additional abortion restriction in states that associated a 7% increase in maternal mortality. States with Medicaid funding bans or physician only abortion laws has significantly higher mortality rates. Late maternal deaths, those occurring weeks or months after childbirth, are also disproportionately high. For example, black women were found to be over 6 times more likely to die from postpartum cardiomyopathy in the months following delivery. These data tell a consistent story. Black women in these regions are more likely to suffer complications, less likely to receive appropriate treatment, and more likely to die from conditions that could have been addressed earlier in the care continuum. One of the most critical maternal health issues in this population is preeclampsia, a hypertensive disorder that can develop after the 20th week of pregnancy. It leads to organ damage, seizure, stroke, and even death if left untreated. Preeclampsia is more prevalent and more deadly among black women, especially those living in urban areas of the Southeast. According to Boyke et al., US born black women had significantly higher rates of preeclampsia than foreign born black women, even after controlling for other health factors. This suggests a strong role of environment and systemic exposure rather than biology alone. Ross et al. Found that higher socioeconomic status did not reduce preeclampsia risk in black women. In contrast, it did reduce risk in white women. This supports the idea that chronic exposure to racism, not income level, is driving these outcomes. Gavoric and Kata 2022 summarized that cardiovascular complications such as stroke and kidney injury are more common in black women hospitalized for preeclampsia. These complications occur at a higher rate even among those with private insurance, which again points to systemic failure rather than patient level causes. When we consider the spectrum of prevention, black women in the Southeast face gaps at every level. At the primary prevention level, there is limited access to community education and screening for hypertension before pregnancy. Structural barriers such as poor access to primary care, limited health literacy resources, and inadequate transportation systems prevent early identification of risk factors. Secondary prevention, which involves early detection and timely management of conditions like preeclampsia, often fails due to delayed diagnosis and inconsistent prenatal care. Joku et al. Point out that black women often have their symptoms minimized or misinterpreted by providers, leading to missed opportunities for earlier intervention. At the tertiary level, postpartum follow-up is often insufficient. McDormand et al. Showed that postpartum cardiomyopathy is the leading cause of late maternal death among black women, many of whom never received the necessary follow-up visits or cardiac evaluations. Even when access to care is technically available, issues like provider bias, fragmented services, and institutional distrust reduce its effectiveness. The end result is a pattern of preventable deaths occurring in women who should have survived childbirth. The structure of the healthcare system contributes directly to the poor maternal outcomes seen in this community. I'll emphasize that black women are more likely to deliver at hospitals with limited resources and lower quality ratings. These facilities often lack adequate staff, equipment, and clinical protocol to respond to obstetric emergencies. The system is also poorly coordinated. Pregnant individuals with chronic conditions like hypertension may see multiple providers who do not share records or follow a unified care plan. Postpartum care is often disconnected from the delivery experience, especially for Medicaid recipients who may lose coverage just weeks after giving birth. To move towards equity, the system must shift from fragmented, volume-based care to value-based models that emphasize patient outcomes, care coordination, and long-term engagement. This includes ensuring that quality metrics reflect racial disparities and that providers are held accountable for closing those gaps. Expanding the perinatal workforce, investing in implicit bias training, and integrating maternal care into community settings can also help rebuild trust and improve continuity. Addressing the maternal health crisis in the population requires structural reform, not small-scale adjustments. To address this disparity, we must align our strategies with the 4 pillars of population health, which are care management, quality and safety, public health, and health policy. Care management involves tailoring support to high-risk individuals. This could include expanding the role of case managers, integrating community health workers, and ensuring postpartum follow-up beyond the standard 6-week mark. Black women are disproportionately affected by late maternal deaths, particularly from conditions like postpartum cardiomyopathy, which requires ongoing monitoring. Quality and safety measures, standardized clinical protocol across facilities. Hospitals serving black communities must consistently implement evidence-based practices like the AIM maternal safety bundles. Howell emphasizes that inconsistent quality of care contributes directly to maternal mortality disparities. Public health efforts must center on addressing social determinants such as housing, transportation, and nutrition that influence a woman's ability to seek and sustain care. Joku et al. Emphasize that these are not peripheral barriers but root causes for poor outcomes. Finally, health policy must focus on expanding Medicaid postpartum coverage, removing abortion restrictions that increase mortality risk, and mandating racial equity audits in maternal care systems. Vilda et al. Demonstrated that each new restrictive policy correlates with increasing maternal deaths. When all four pillars are addressed together, they create a strong foundation for measurable and lasting change. Unfortunately, recent developments in healthcare policy have only made the situation more urgent. Several states in the Southeast have introduced or implemented Medicaid cuts or restrictions that limit postpartum coverage to just 60 days. This is dangerous given that over half of maternal deaths occur after childbirth, especially among black women, as reported by Bison et al. And McDormand et al. Simultaneously, we are seeing an increase in restrictive abortion laws across this region. Vida et al. Found a clear association between these abortion restrictions and maternal mortality. These policies are not protecting life, they are increasing risk and reducing options for women with high risk pregnancies. While some states have taken action to extend Medicaid coverage to 12 months postpartum, others have not. This patchwork of policy leads to inconsistent care and deepens the geographic health divide. If maternal health outcomes are to improve, policy must reform, focusing on expanding Medicaid, eliminating insurance churn, ensuring access to full reproductive health services, and holding hospitals accountable for racial disparities in care. Until these policy changes are made, we will continue to see preventable deaths in communities that are already underserved. Thank you for taking the time to listen to this presentation. The health of black women in the Southeast United States deserve focused attention, sustained policy action, and accountability across every level of the healthcare system. The information I presented was grounded in peer-reviewed literature, government data. Full citations are provided on the reference slide for anyone interested in exploring these issues further.